Thank you everybody for joining, and I'm finding it a thoroughly enjoyable day so far. I kind of going to start with looking at the topic of my talk, which is self-medicating in a difficult world. Just a little disclaimer, as Connor would have started his talk with. I work for the HSE, which is similar to the NHS in Ireland. It's a public service, a public health service. But here on this format, I'm speaking in my own personal capacity, even though I may be drawing from examples and perspectives from my work within the addiction services, or the substance abuse services, as we now call them. And I also have to acknowledge and be grateful for some of my colleagues who are past and present, who are actually here on the platform with me as well. So first of all, to declare my interest professionally, I've worked in the addiction field for most of my adult working career. Currently, I work in the adolescent substance abuse service for clients who are up to 19 years old. And this is based in Dublin, in Ireland, in a very poor and impoverished part of Dublin, which is Tallaght. But in my working career, I've always worked I've worked in the adult addiction services as well. So the little head that you see here on the image is looking at our issues of self-medicating in a difficult world. And particularly my personal interest, as well as my professional interest, is that I live in a neurodiverse family. With both members in my immediate family and also in my wider family who are neurodiverse, whether that be on the autistic or autistic young people, or also adults with learning issues as well. Once I've declared all that, so today I'm going to discuss self-medicating, and really how it's important that if we are discussing trying to make services more neurally inclusive, we also have to look at the substance use services, and how are we trying to make substance use services more inclusive of people who are neurally diverse, how to make them more accessible, and also kind of what are the issues that people have. So firstly, what we look at is identity first language. You could actually say that the substance abuse, or the addiction field as it was called in the past, was one of the first places that actually began to get people to self-identify. We would have encouraged people to label themselves as addicted or being an alcoholic, as a way of kind of embracing what their issues were. Now we kind of look at that slightly differently. The language of addiction has begun to change quite a lot. So now we would look at a person in an addictive relationship with substances. Because particularly in the past, people would have seen that once you're addicted, you remain addicted. Now we know that people's relationship with substances can change over time. So we look at the relationship that people have with substances, particularly when we're dealing with young person services like I work in now. A lot of the time you're looking at, if somebody gets a label of being addicted or having a substance use issue at a very early age, that label will tend to stick. So now we talk about their relationship with substances, because you can always change your relationship. It's like my relationship with my mobile phone. It can be very intense at times, and then all of a sudden I can put it down. So we tend to look at substance use issues in the same way now. So we often we've changed in that we now use substance use disorders as a way of looking at people whose relationships with substances has developed into a problematic relationship. When I'm talking about substances, our biggest one is always alcohol, particularly in Europe. And so a lot of the time we're talking about people with alcohol issues. In the younger population, we're particularly talking about cannabis. So those are the two biggest kind of substances that we would deal with. Thankfully, as my colleague Dennis Murray, who is on the platform here, would say, we haven't had a huge issue with heroin or anything like that in our services in quite a while in the under 18 services. But particularly we're looking at all of these substances and how people who are neurally diverse use substances in certain ways. We also talk about affected family members. And I'm conscious that there is a huge proportion of people who are like my age, who would not have been diagnosed with any neurodiversity because it wasn't a thing when we were going to school or when we were growing up. It just wasn't there. So particularly when we look at how older populations deal with substances, and particularly older people who are neurally diverse, would, may not have been able to avail of services that younger people can, but would have used substances as a way of self-medicating. So the next slide that we look at. So if we look at the research picture, so for this talk, I kind of tried to look at the research picture to have a look at what research was out there about neural diversity and substance abuse. And a lot of the time you can see that on the left, on one side of the screen here, we have some of the ways people would have researched it. They would have looked at medical conditions, people who have autism, and what are the medical conditions that they are seeking help for, and trying to pick up alcohol or substance use as a comorbidity or something that was listed in their kind of surveys, and trying to deal with it in that way, or pull out figures in that way, I suppose. Most of these would have been quantitative rather than qualitative studies. They would have looked at psychiatric conditions and seen, okay, how many people had a dual diagnosis of neural diversity and a substance use issue, and then would have looked at use of services, how many people were classed as or diagnosed as autistic and being recorded in the services. And the conclusions that they came from some of these large studies and smaller studies were that there was a low risk because of some of the behavioural and risk averse kind of issues that the neurodiverse population was dealing with, that they would be at a low risk of developing an addiction. That kind of fed into the clinical picture as well. But now we know that in the wider population, so there were bigger, wider population studies on the right-hand side of your screen, where, you get vastly different kind of ideas around how many people in the neurodiverse population will have a substance use issue. Some figures, if you look at this, one systematic review said from 1.3 to 36%. And you kind of think, well, that's very wide. How wide is that? So 1.3 chance or a 36% chance of dealing, or my child has those kind of issues. So particularly the research picture around substance use and neurodiversity is very, very poor. So we tend to look at what the clinical picture is and see that as a better kind of avenue. Now, most treatment demand indicators, which are what we use in the treatment services and substance use services, we fill in statistics, which are called treatment demand indicators. They don't record neural diversity. They don't record if somebody has ADHD, ASD, or any of these kind of issues. Some of the research is quite interesting in that they would have tried to predict, and they would have said, okay, somebody who has autism and ADHD is much more likely to develop an addiction issue. Somebody who has autism and maybe has an intellectual disability is less likely. So again, they were making all of these kind of very wide swinging kind of hypotheses about substance use and neural diversity. So that's just to give the kind of research picture, which can be quite upsetting if you're reading some of the documents that people have produced over time. One or two that are really interesting, Elizabeth Weir did a really, really nice kind of study that came out in 2021. So some of the more recent stuff is actually much more balanced around neural diversity. And her study looked at that people who are autistic are 9 times more likely to use substances to manage their behaviour, to eliminate control, and to reduce sensory overload. So particularly when we're looking at, for us, sorry, I'll just move my next slide. For us working in the substance abuse field, one of the things that I went back and looked at was I picked a month last year and kind of looked at for our service. Now our service is an under 18 service. So at that time we had 41 open cases. 36% have had a diagnosis of neurodiversity. So they were either autistic, had ADHD, or would have had speech and language learning disability, or what would be classed as dyscalculia, dyslexia, all of those kind of issues. And particularly 12% were waiting for assessment, or hadn't been assessed, or we were actually suggesting an assessment. And 48% of our clients at that point were neurally diverse. So over half of our clients were neurally diverse. So when I came into the adolescent service, one of the issues that we began to see, myself and my colleague Emer, began to look at of how are we going to include these clients in, and how are we going to adjust our service to make our service more neurally inclusive. And particularly, I don't think we're unusual in that many substance abuse services would now recognise that a huge proportion of neurally diverse people are using substances, are using alcohol and other substances to try and manage some of the issues that their neurodiversity brings into their lives. So, particularly what we look at is that people can be dialing up or dialing down. We always thought of dialing down, that people were using substances like alcohol, cannabis to kind of dial down feelings or emotions and dial down anxiety. Now we know that people can be dialing up as well. If we have people who have alexithymia, who have a lack of sensation or need a big message from their sensory system, they may be dialing up with substances. So for example, they may be using stimulants to try and actually feel things, to try and allow themselves to engage with society, and that relationship with substances can be very beneficial at the start, where, you know, the old saying we have in Ireland, it gives people Dutch courage, which is the ability to go into a social situation. So they can be dialing down some of the sensory issues to allow themselves to socialise, to allow themselves to deal with feelings and emotions and move out into a neurotypical environment. The other thing that people can be doing is dialing up. So a lot of the time we would find that our young people are trying to find an identity, to begin to use substances to find a tribe, to use substances to control their symptoms, and to either escape a diagnosis as well. We would have some young people who don't accept their neural diversity and would be using substances to fit into a neurotypical world. And again, whether that's masking or whether that's constructive use of substance is another issue. So particularly for us, and trigger warning before I go to the next slide, I'm going to put up a kind of composite picture of what we would tend to see in a young person who actually attends our service, and some of the issues and labels that a young person would have gathered as they go along. So being neurally diverse and having a substance use issue as well can be doubly labeling, because on the one hand, mental health services may not deal with you if you have an addiction issue or if you have a substance use issue, or see you as having a substance use issue. So particularly one of our clients looking at, and again, this is a composite, Emily, referred by CAM's team where she was attending for the last year, 13 at the time, diagnosed with dyslexia, dyscalculia, sensory processing issue, has an ASD diagnosis, has an older brother, age 21, who's also neurodiverse, mum and dad, so suicidal, emotional dysregulation, anxiety, and oppositional defiant kind of behaviour would have been the labels that were in the referral letter that we would have got. Vulnerable sexually, as in she was looking for her tribe, which meant that she was at risk of exploitation as well, because not understanding the social cues and adding in cannabis particularly on top of it. Using weed daily at 12 and 13, going missing, not attending school, does not like her school class, because again, she would see herself as being different from most of her school class. She was in a special school, and wouldn't see herself as being part of that diagnosis. She didn't particularly like the diagnosis. So I'll move on from that, because again, you can see that a lot of, when we're looking at a lot of the labels that our young people would have, when you begin to work with them on their sensory issues, and when they begin to cut down on the thing that they would have seen as helping with some of their sensory overload. So the light bulb moments that we kind of had as a service, we began to look at anxiety-based avoidance. We began to look at clients and young people who were exited from mental health services because they couldn't come for appointments, because they were using weed before they went to the appointment to try and calm themselves down to go into the appointment. So we began to try and develop strategies to kind of cope with anxiety-based avoidance. So that means kind of when a young person attends our service, we will show them around and show them into every room in the building, apart from our filing room, but we'll show them the door. And we give them a tour of the building before we actually would agree to them coming. We would also look at, for some young people particularly, we will give them a lot of choice around our services. So the second thing that we did was we used the experts by experience. In Ireland, we have an autism charity called As I Am. We got funding for them to come in to do a sensory audit, to look at all of our rooms and look at how do we need to deal with the lighting? How do we need to deal with the furniture? You know, what kind of things should we offer people? We developed a client's charter that's an neurally inclusive client's charter. So clients have choice over how long their appointments can be. If they're able for appointments, standing up, sitting down, walking around the car park, we will do that as well. Particularly things around staff training, that we began to look at our own needs around staff training as to how we offer our young people, you know, services in a way that we're dealing with substance use, but we're also looking at how do we need to advocate for them with mental health services? How do we need to advocate for them so that they won't be kind of excluded because their behaviour might be a bit different, even when they become sober, when they become drug-free. We test out with young people, we ask them, and particularly we ask our neurally diverse young people as to, does this work for you? We give people options of giving us messages verbally and non-verbally within sessions as to how they're doing. So we have a sensory box in each room that has sunglasses, earplugs, fidget toys, hard and soft fidget toys, and kind of a way of telling us whether they're okay to talk or not okay to talk, because sometimes talk therapy isn't always what people are able for. So it has helped to redefine our ideas about the pathways in and out of substance abuse, and particularly because the substance abuse area would have a very definite kind of pathway of, you know, somebody's substance use escalates to a certain level, then they need to go into treatment, then they come into recovery, and there's a very defined pathway about what recovery is like. Our neurodiverse clients are teaching us that that can be quite different. So we have clients who would decide on a Friday that, right, I'm giving up weed on a Monday, and they will actually do it. And we kind of have to adjust to that our own pathways are the things that we were trained with around how people come into substance use and how people exit from substance use, have to kind of be redefined. For the young person's population, this is an easier sell than for an adult population. Family therapy and working with parents is kind of part of our job and part of our remit. For adult services, family therapy is very thin on the ground and not really included in adult substance abuse services. So again, in the adult population, we would have lots of adults who are dependent on parents to try and help them to navigate. But the problem with that is that once you pass a certain age, once you passed the age of consent in Ireland, once you pass 18, your parents have no right to attend services with you, or your support person has no right to attend services with you. So things like that can be quite difficult. If somebody needs a partner or a family member to be with them or to be in the room with them, that can be quite difficult for some services in that they won't allow that to happen. So again, for our work as family therapists then in the service, it's really to work with parents also to try and look at bringing the whole family into a different way of navigating around what is it like to be neurally diverse and have a substance use issue. Because lots of parents would have certain ideas around, you know, young people may have received a diagnosis very early on. For a young person who's now a teenager, some of the descriptions that parents had developed as when they were younger don't tend necessarily to work with young people who are actually using substances to try and cope with the world around them. to try and find a way of interacting with the world that works for them. And also because young people are using substances, and adults can be using substances as an alternative to medication, in that they may not want to interact with the services and mental health services, and they may choose to use substances to do that. There is a huge kind of issue around the idea that cannabis will help with anxiety, and people will be using cannabis to try and cope with anxiety. And again, whether you agree with that or disagree with the legalization, for us in the under 18 services, it's not going to be legal for under 18s anyway. So a lot of the time we don't have those issues. But particularly our young people, I think one of the things that we look at is that we are actually learning from them as to how to change the service around that will be neurally inclusive. We do it for all clients rather than just for our neurally inclusive clients. The idea is that it benefits everybody. It's not going to harm any of our neurotypical clients, but it's really going to help our neurodiverse clients to engage with us as therapists.